We continue our discussion on diabetes. Now I will be talking to you regarding types of diabetes. Well, traditionally we divide into two categories, type 1 and type 2 diabetes. But I like to tell you something, that first of all, not only there are type 1, type 2, there are many other types of diabetes also, about which I will be talking to you in the next lecture. And one more thing, and very important point you got to remember, the ratio of type 1 and type 2 is 5-95%. The usual type 1 is only 5%. This is a very important point that you got to remember. What is the applied part of this statement? As 95% is type 2 diabetes, so whenever we talk about diabetes, or if you get any question on diabetes, if he has written only diabetes, it is understood that the examiner is asking regarding type 2 diabetes. Why? 95% the type 2 diabetes. Okay. With this background of the basic concept, we move further. Let's talk about the clinical feature of type 1 diabetes. These patients are usually below 40 years, or sometimes they say young adults they can write. But now I like to tell you something. It is usually. What the importance of the word usually, I will be talking to you in a minute only. Well, regarding the weight, let's presume that I am talking about a young child about maybe 10 or 15 years who is diabetic. So he will have normal weight, or usually they are underweight also. And most of the time they have autoantibodies, islet cell antibodies, or anti-glutamic dehydrogenase antibodies. Okay, but there is one more entity where we can have type 1 diabetes without antibodies. Why we call them type 1 diabetes? Because the basic problem in this is beta cell destruction. So in a traditional type 1 diabetes, these antibodies they destroy the beta cell. As the beta cell are destroyed, and that lead to reduced serum insulin level. But there are many cases where beta cells are destroyed, but there are no autoantibodies, what they say, perhaps due to viral infection. That is why we call them as type 1b diabetes. There is again destruction of beta cell without antibodies by viral fever, we call as type 1b diabetes. And family history of diabetes may or may not be there in type 1 diabetes. Well, since there is an autoimmune destruction in most of the cases, the patient may have other autoimmune disease like Graves' disease, Hashimoto, pernicious anemia, Addison disease, celiac disease, or maybe so-called polyglandular failure syndrome called Schmidt syndrome. Serum insulin level are reduced. Why? Beta cells are destroyed. HLA, DR3, DR4, very important question. This is again a very important question, and main treatment is insulin. Now, as I was talking to you, that main pathophysiology is autoimmune destruction of beta cell because of so many antibodies, and I also mentioned that there are some patients where beta cell destruction occur without antibodies, so called type 1b. This is due to viral infection, the point I mentioned to you. Now let's learn temporal model of development of type 1 diabetes. First we see the slide, then I will be discussing this thing. So we have one patient. This is beta cell mass. It is almost 100%. So we have some patient who have a genetical predisposition. Okay, beta cell mass is normal. And now immunological trigger starts. Remember it. Most of the time it's a autoimmune destruction of beta cell. And immunological abnormalities they start appearing. That lead to progressive destruction of beta cells, and that lead to progressive impairment of insulin release, and this comes to stage 1. More destruction, stage 2, and finally stage 3, that is diabetes is there. Up to this no diabetes, but here diabetes is there, and this is stage 3. No diabetes and diabetes. Now I will be talking to you more about this slide, and I request you, before you see the next slide, you can draw this diagram, label it properly, then you will understand better. You can stop the video if you want. So I presume that you have drawn the diagram. So let's talk about temporal model for development of type 1 diabetes. Individual with genetic predisposition, underline this word, triggered that initiate autoimmune process, and that lead to development of islet cell antibody, and that also lead to destruction of beta cell, and that lead to gradual decline in beta cell mass. Stage 1 is characterized by development of 2 or more islet cell autoantibodies, but still the blood sugar, random blood sugar is, or what can say, blood sugar is normal, fasting PP is normal, although autoantibodies are there. Stage 2, that we remember, in stage 1 antibodies are there, but beta cell mass is normal. Okay, so that beta cell mass is reduced, but sugar is normal. Stage 2, continued autoimmunity, and now start development of dysglycemia. That means the difference between type 1 stage 1 and stage 2, we got some disturbance of glucose level is starts occurring. And stage 3, what we defined as classical hyperglycemia which exceed now diabetic range. Now patient has overt diabetes. So in nutshell, what I can say, stage 1 autoantibodies present but blood sugar normal. Stage 2 autoantibodies are there, but there is some disturbance of blood sugar level. Stage 3, where we have definitely diagnosis of diabetes. I hope you know that fasting more than 126, random blood sugar more than 200, or after OGTT 2-hour value more than 200, or HbA1c more than 6.5%. I don't think you need to write this. We have discussed in part 1 of the diabetic lecture. So now this is frank diabetes stage 3. Well, in the initial phase of type 1, 1 to 2 years after onset diabetes, patient may be associated with honeymoon period. That means sudden some illness occur, requirement may be normal. This is diabetes. Suddenly some illness occur, patient goes, maybe may develop some amount of diabetes, but again illness goes, patient come to normal. So that period, this period is known as honeymoon period, where patient may be requiring less amount of insulin, but it occurs in the initial phase of type 1 diabetes. What are features of type 2 diabetes? These patients usually have overweight and no antibodies, no autoantibodies. Ketosis is not seen or uncommon. For non-ketotic hyperosmolar coma, this is very common. This is common if not treated properly, of course. Family history is strongly positive. Insulin resistance is there, and initially serum insulin level are very high. That means a stage of hyperinsulinemia. Treatment is weight reduction, oral hypoglycemic agent, and lately insulin. Insulin is required in some cases only. But the question is, in these cases serum insulin level is more than normal, but still the patient is hyperglycemic. Why? This I am going to discuss soon. Well, what are the causes of why hyperglycemia occur in type 2 diabetes? First of all, increase glucose output, glucose output from the liver. This is due to increased glycogenolysis and gluconeogenesis. Reduce peripheral utilization of sugar and reduce insulin release from pancreas. Now What is the pathophysiology of type 2 diabetes? Defect may lie in the receptor, post receptor or GLUT4 defect. Reduced receptor due to adipose tissue. What is this? I am going to discuss soon. And post receptor defect. This is due to tyrosine kinase defect and GLUT4 defect. Normally GLUT4 move from systole of cell membrane to attach to glucose and bring glucose in the cell. This is the cell, this is glucose and this is GLUT4. This goes to membrane and bring back sugar into the cell. But this movement is defective, GLUT4 is defective. So there are three different ways why hyperglycemia occur in type 2 diabetes. So let us see the graph. Again, you can draw the diagram. Here is the insulin secretion. Here is the insulin sensitivity. Stage A, stage B, stage 3, stage 4. This is normal glucose tolerance, impaired glucose tolerance and type 2 diabetes. First you draw the diagram and the next slide I am going to explain to you what is this diagram. So now detail about the slide. Metabolic changes during the development of type 2 diabetes, the heading. How it starts? Insulin secretion and insulin sensitivity are related as individuals become more insulin resistant by moving from point A to point B. More and more resistance is going on. Insulin secretion increases. Look, insulin level is secretion is getting increased. Resistance increase. As a failure to compensate by increasing the insulin secretion result initially impaired glucose tolerance, and later on type 2 diabetes, this is D. But remember insulin level is much higher and later on still goes very high. So that is why in case of type 2 diabetes hyperinsulinemia occurs. Now let me discuss difference between type 1 and type 2 diabetes. Age of onset usually below 40 years. By now you know because we have an entity called as LADA, which is a kind of type 1 diabetes which occurs in the elderly person. So that is why we use the term as usually 40 years. This is usually above 40 years, but do not forget we have a term called MODY, which is a kind of type 2 diabetes which occurs in the young patient. HLA association, HLA DR3, DR4, there is no association. Body weight normal, sometimes they may be underweight, but here they are really obese. Family history may or may not be there, is strongly positive. And in this case it is definitely positive because this entity is autosomal dominant. Then presentation usually abrupt. Sometimes it may be the initial presenting feature also, but here it is very gradual. And rather most of patients they remain undiagnosed. 50% patients are diagnosed incidentally. The patient may be having going for some insurance checkup or some annual health checkup, then they find patient has diabetes. So most of the time there are no symptom at all. Treatment is insulin requirement is absolute, but drug like alpha glucosidase inhibitor, pemvidutide can be given. But here we can give oral hypoglycemic agent and insulin come much later on. Serum insulin level is highly reduced, they are highly increased in the state of hyperinsulinemia initially at least. In the very advanced stage here also insulin level may go down, but initially serum insulin level is very high in type 2 diabetes. Etiology is usually autoimmune or viral also. Here insulin resistance is the main feature which is due to obesity. Now why obesity lead to insulin resistance? This is due to down and up regulation of receptor. So let us learn the basic concept about this entity. What is this? And this is how you are going to explain regarding insulin resistance and increased body weight. Well, we all know very well that this is the cell, and here we have beta cell, of course, pancreas. Here we have receptors. R for receptor for glucose by which it get attached, and insulin is reduced. And this is a tyrosine kinase receptor. So as the body weight increases, the number of receptors, they go down. So this is known as down regulation of receptor. Okay. So now the patient loses the body weight, the number of receptor go up. This is known as up regulation of receptor. Well, just now we learned that in case of type 2 diabetes, insulin level is very high, but still he is hyperglycemic because number of receptor are reduced, so called down regulation of receptor. That is why when we will manage a case of type 2 diabetes, our main aim is to reduce body weight. The body weight reduction is the most important thing. Once the patient loses the body weight, the automatically number of receptor go up, and that lead to, and already insulin is there. About 25 to 30% of the type 2 diabetes we can just treat by diet and exercise only. I hope you learned the concept of down and up regulation of receptor and why weight loss is so important in type 2 diabetes treatment. Okay, this is the same what I have written for you. Now 50 gene, this again an absolutely new concept. Down and up regulation of receptor is very important. This is in prospective new question. 50 gene is concerned with overeating. Overeating lead to obesity. Obesity lead to insulin resistance. I for insulin, R for resistance, and that lead to diabetes, type 2 diabetes. Okay. So first we learn what is this, why they are related, and how the thing is there. For that we talk about history of human being. Thousands of years back, when the human beings were living in jungles, they used to kill one animal, and in those days also there was a tendency to overfeed the pregnant lady. Why? It was a custom that time also to overfeed the pregnant lady, because that in those days it was not sure when they will get the food next time, because every time they have to kill the animal to feed. So that was a tendency to overfeed the lady. In due course of time, we have developed genes which have tendency to overeat, so called thrifty gene. But nowadays, when the food is in plenty, we have a very lavish breakfast, and we know we have a lavish lunch, we are going to have a lavish dinner also. But still human beings have a very tendency to overeat, and that's why most of us are getting obesity, but all due to thrifty gene which is there in our body. Okay, so I hope you are clear about the concept of thrifty gene causing obesity. So next time you happen to go to any party and you find somebody has overfilled the plate, okay, overeating somebody you find, then what you say, oh, thrifty gene is operating, and that time you will think about me also. Dr. Bhatia discuss about thrifty gene. I hope things are clear to you. Okay, same what I have written for you. So a quick recap of the last minute revision point what we learned in this lecture. We have type 1 diabetes, autoimmune, type 2 diabetes, overweight, insulin resistance, MODY is autosomal dominant, type 2 diabetes, LADA is type 1 diabetes in elderly person, and down and up regulatory receptors due to insulin receptor problem, and thrifty gene is concerned with overeating. Thank you very much for watching this video.